Hello everyone, welcome. Today's topic of discussion is contrast-enhanced nephropathy. Essentials of diagnosis: rise of serum creatinine greater than 0.5 mg per deciliter or 25% above baseline creatinine within 48 hours after IV contrast administration. Majority of cases are non-oligouric. Peak in serum creatinine occurs within 3 to 5 days with complete resolution in 7 to 10 days for most patients. Oliguria and need for dialysis are unusual and are primarily seen in patients with diabetes with severe chronic kidney disease. Contrast-enhanced nephropathy is an independent predictor of mortality. Nearly 60% of patients with contrast-enhanced nephropathy have significant chronic kidney disease. Differential diagnosis includes renal atherosclerosis seen in patients receiving contrast, and it may be accompanied by livedo reticularis, digital ischemia, retinal embolization. Acute tubular necrosis is another differential of contrast-enhanced nephropathy, especially in unstable patients getting contrast studies. Allergic interstitial nephritis, obstructive nephropathy. There is no specific diagnostic test for contrast-enhanced nephropathy. Urine typically shows sign of tubular necrosis with muddy brown casts. The FeNA, fractional excretion of sodium, may initially be less than 1%. Treatment: no specific therapy for contrast-enhanced nephropathy. In severe cases, may need hemodialysis. Preventive strategies are important and include minimize contrast exposure or volume, IV hydration before the procedure, avoid nephrotoxins and NSAIDs, possibly N-acetylcysteine and sodium bicarbonate. So the clinical pearl of contrast-enhanced nephropathy occurs predominantly in patients with CKD, and preventive strategies are critical as no specific therapy exists. Thank you very much.